and as most countries, those subjects are in the field of, as I said, maxillofacial surgeons. But at least we have to know what is that and what exactly we can do with that things in our practice, at least to diagnose it and send that patient to proper place to solve that problem. Okay. Let's move. So what is abscesses? It is limited accumulation of pus in tissues and organs as a result of prolonged inflammation. Have to say, I mean, it's 100 times I said that, and I keep saying that. All those lectures, I don't have much time to fix it, and there's a lot of grammar problems here, and I know it, but I just really have no time to deal with that. But still, in common meaning, you're gonna understand what is that, okay? Okay, because it mostly Google Translate. Mi scusa, but still. So etiology, yeah, I prefer the British grammar, so it should be A at the end, okay? But still, in secondary disease maxillofacial, the areas are infectious and inflammatory in nature processes that is cause microorganisms, most of which are in ordinary conditions, vegetates on the skin and mucous membranes of oral cavities. So we call that just typical microorganism. There's absolutely you and me and everyone here have everyone has that the same microorganisms, but we have the background. The background is immunity. So when our immunity broke, we have some problems with that. In a case of violation, integrity skin, integument and mucous membranes, lesions marginal periodontium, as well as destruction of tooth tissues with exposure its cavities. These microbes penetrate into the tissues. Their further fate may be different. In some cases, they die in the zone penetration under influence protective factors. In others, with the flow of lymph reach lymphatic nodes where it happens, their fixation and destruction. But if lymphatic nodes are not capable fully, they capture and destroy microbes. The last penetrate the bloodstream with the bloodstream and can be carried to any organ. However, it is often observed another consequence. Microbes that have entered the tissues adapt to the new conditions of existence, begin reproduce. And after that, we have problem that calls abscess. Of course, it works everywhere absolutely the same way, but we talk about abscesses of maxillofacial region, but the algorithm the same everywhere in all organisms. So no big deal. But there is some kind of difference, some particularities, okay, that connected with some features of maxillofacial region. A lot of vessels, a lot of organs, a lot of very specialized structure as eye, brain, the mucous, the salivary gland, and others. Okay, so there's a kind of particularities. Hope you understand that. A number of them produce toxic substance. It means microorganisms produce toxic substances, protein nature. It calls exotoxins, which have antigenic properties and are capable selectively amaze those of other tissues. As a result, death and decay microbial cells are also released from a toxic substance, and we call that endotoxins, action which is not characterized by specificity, causing damaged tissue structures, toxins, thereby causing development inflammatory reaction, which is ultimately directed, resulting in restriction zones spread microbes, their destruction, and elimination. With the appearance of the first signs, these one reactions can to talk about the beginning of a local infectious process. Its emergence depends, it should be on virulence, infectious origin, pathogenic properties, microorganism, their quantity, as well as from equal immunological reactivity microorganism. For example, its abilities response to an infection agent with a protective adaptive response reaction, including. In other words, for the beginning local infectious inflammatory process, a critical concentration. That's very important things, critical concentration of the pathogens in required disease, which is lower than higher is pathogenic properties. That critical concentration is a key condition for beginning of the inflammatory process, because as I said before, the microorganisms, the typical microorganisms like staphylococcus and streptococcus and others, there are a lot of those microorganisms in our organism, but still we have no abscesses, right? Because our immunity system works, the immunity cells work, and as I said, should be some background of lack of immunity system and the critical concentration of microorganisms, and then we have abscesses, but not necessary. Our organism is very hard structure and very complex system. I mean, the organism itself. So it's not so easy, even if even if you really want to have abscess, it's not sure you're gonna have that. Not so easy, but still, So we have some classification. Of course, as I said many times, any classification is very, very not necessary thing, but it helps you to describe your problem in the documents. Documents means medical documents, okay, that you filled as a doctor. So we have all phlegmons and abscesses per maxillary soft tissues can be divided into few sorry, oops, okay, into few types. Of course, it depends on source or origin of infection. Very, very obvious. Odontogenic. We have odontos in ancient Greek is a teeth, okay, and genesis in ancient Greek is development. So odontogenic is it means the source of infection was in some problem teeth. Okay, that's very obvious. And if we talk about tonsillogenic, of course, we talk about tonsilla, and that was a source of infection. And stomatogenic, it means stoma, it means just oral cavity. And we call stomatogenic when the source of infection was the mucous membrane of oral cavity. Okay. adenogenic and osteogenic and traumatic origin is very obvious, very obvious. Greetings, Miss Olena. We have just 4 students from 5. I don't know where's the 5th one.
Ok, дякую.
No problem. We missed. Oh, here we go. Yeah, that it is. So when we talk about traumatic origin, it means that we have some trauma. Okay, it could be anything, as you can see, gunshot, a non-gunshot wound, hematomas, a separation of hematomas and others. Do you understand what is a gunshot wound, right? Anyone? Amal, if you're trying to say something, I don't hear you. I'm just checking if someone listening and anything.
Can you hear me now? Hello?
Yeah, I hear you now. Okay.
Oh, yeah, okay.
Yes, we are listening.
Yes, we know. I know what is gunshot.
Yeah,
yes.
but I ask you, do you know what is a gunshot wound? Okay.
A gunshot.
Yep.
A gunshot.
Yeah.
Yeah.
Okay, so you
Yeah.
understand what is that. So we have some
Yes.
weapon, okay? So
Uh-huh.
weapon, and there is some bullets, and when you
Yes.
just shot someone, you have a gunshot wound, okay? So the gunshot wound could be a region of the problem that goes into abscesses or phlegmons of maxillo-facial area. Of course, the gunshot wound of maxillo-facial area. Okay. Whew. In the clinic maxillofacial surgery, most often we have odontogenic processes, of course. Why so? Because if we talk about tonsillogenic or adenogenic and osteogenic and others genic, the patients they just go into other doctors, okay? So for them, it's not so obvious to go to dentist or maxillofacial surgeon. But still, you as a dentist-chirurgien in Morocco, I hope so, right? You're gonna be a dentist-chirurgien. You're not gonna treat those things. I think, I'm not sure, but I'm think. So if patient addressed to you, you could write some document, not sure how you call that in your country, with diagnosis or pre-diagnosis. I mean, you're not sure at 100%, but still you see that it's some kind of problem, maybe fracture, maybe gunshot, maybe odontogenic, periodontitis, periostitis, and osteomyelitis, as we talked at the previous semester. You put that diagnosis there and address that patient forward
Yes.
to the proper
Correct.
place. But your
Yes.
name,
Here in Morocco, we guide the patient to the maxillofacial
yep,
with
absolutely,
a prescription of a 3D scanner.
of course. But
Yes.
you put your name, Aid
Exactly.
Salem Amal, okay,
Yes.
doctor. She did
Yes.
that. So
Report.
Aid
Yes.
Salem Amal should know what exactly she see, okay?
Yeah. Exactly. It's a
You
report.
have my point.
Yes,
Yeah.
we write a report, like
Yep.
a pre-diagnostic.
Yep, as I said,
Yeah.
absolutely correct.
Yeah.
So that's why we talk about these things here. Just you to know at least basic things about that. Okay, place penetration marking again is blah blah blah. I'm not sure I should read all that things. penetration prelit microflora, hematogenous root. Not root, it should be away mostly. Okay, hematogenous or lymphogenous way of how those microbes reach that place. It could be hematogenic with blood vessels or lymphogenic with lymphatic vessels, but it's very hard to prove. It's very hard to prove exactly hematogenous or lymphogenous way of infection, but still it exists. It could be, and you should remember about that. So not necessary your microbial region should be in the same place where you have abscesses, so phlegmon or peritonitis or osteomyelitis. So it could be like 10 centimeters left, for example. Okay, the frequency emergence, originality, clinical course, and 70th prognosis in the centimeters are determined by topographic, anatomical, and immunobiological features. This one includes presence, teeth, and branched lymphatic apparatus. Proximity to the brain, absolutely yes. Visual analyzer, it means eye, right? It's just like medical, very uh how to say that? The notion like soulevé. I understand that.
Yeah.
Initial department esophagus and upper respiratory way, sorry. Possible disruption, infectious process alone, neurovascular bundles, neck, pharynx, esophagus, and mediastinum. I hope you remember what is a mediastinum is here. All our problems here could down for the mediastinum. It does a huge problem that is not a maxillo-facial area anymore, and we have to give that patient into the thorax surgeons. Thorax means like who work here. Okay, let's move on. Okay, another classification. It's very easy one of the easiest classification. We just divide into abscesses and phlegmons of tissues adjacent to the upper jaw and to the lower jaw. Very easy. So in each type, we have superficial, deep, and secondary. It's very obvious. Superficial, deep, and secondary. Secondary, it means it happens after some different from different regions. Not that was not primary region. Whew, I hope you understand it. If you have some question, you can ask me anything. Any questions?
No, it's clear.
It should be maybe one year we have to switch to French, right?
Yeah,
Yeah, French for you would be more easy, maybe.
easier. Yeah.
Easier, 100%, but where you have to find a lot of teachers who speak French, not
This
sure.
is the hard part. Yeah.
It's the hardest part, yeah, because it's not so common here. Not many people know French, almost no one, but still. Borderlines. Very nice picture, actually. I found it and I put the copyright below. As you see, I didn't steal that anywhere. I said, okay, it's Trifanenko. It's from Bukovina State Medical University. Very nice picture of a region or borders lines that you can understand which region or area um, which is the borders and how to describe it correctly in your documents. So infraorbital region, we have zygomatic, we have parotid chewing, we have extramaxillary, submandibular, buccal, mental, and submental. Of course, I didn't check those names. Really didn't check in English-speaking literature. I'm sure that it should be some difference, of course, because as I said, I just have no free time for that. I just don't have free time, sorry. But I'm sure that you're very smart and you find anything that you need in your books. I have to ask the Yasin to turn off your microphone. We are very glad that you working into supermarket to buy ice cream, but we don't want to hear that. Yasin.
Yasin, Mike. Yasin. You can't hear us.
Mais c'est quoi ce bordel-là? Yasin. Okay, we forced him. Hop. Nice. Let's continue. We're very glad that he went to supermarket to buy an ice cream, but we don't have to know about that. Right, Yamal?
Exactly.
Exactly. Okay, is ice cream popular in Morocco, right?
Very, very popular.
Yeah,
Yeah.
in the winter. Very nice.
Exactly. It's the best time to take ice cream. It's winter, not summer.
Absolutely. Absolutely.
Yeah.
Okay. Submental area. We have a description of the borders. Not sure that I have to um, read all that things. We have triangular space. You know that very well. So about inflammatory process here, submental area. It is characterized by swelling downward from the chin. Yes, submental is here. Usually with abscess submental plots, the skin in this area happens only slightly infiltrated. I remind you that it's a Google Translate, so mi scusa. Its mobility initially a little limited, so not so easy to move it, right? And sometimes with 3-4 days occurs dense infiltrate from significant edema surrounding tissues. In the future, skin that covers swelling gradually turns red. In the area, infiltrate appears fluctuation area. Very bad, but still understandable. I have to remind you about that abscesses and phlegmons as inflammation still the typical pathological processes. So they have all those 3 stages from alteration, exudation, and proliferation, and they have 5 signs. Tumor, rubor, color, dolor, functionalesa, all 5. So still with abscess and phlegmons, we have the same problems because it's typical pathological process, like periodontitis, like pulpitis, like everything else, but still it's inflammation. With phlegmons, segmental plots already at the beginnings of the inflammatory process is determined, infiltrate, usually large, symmetrical, situated concerning average line's body. In this case, mostly there is no difficulty swallowing and breathing. Opening the mouth is not limited, only with large purulent foci in the segmental area. Oops. 2 times area, okay, especially extending to the surrounding area of fabrics, fabrics, not fabrics, it's tissues, it means for tissues, okay, surrounding tissues, limited dropping lower jaws. In the future, is purulent melting of tissues in the submental area, infiltrate, softens. It means it makes more soft and begins to be determined fluctuation. Fluctuation is a pathological sign when you sign when you feel some liquid moving under tissues. It's very specialized pathological sign. With abscess and phlegmons, chin, plots, mucous, shell, or a cavity in the sublingual area in both the front and side departments has not changed. That's very disaster. Actually, I should say it's not gonna look like this. Not should look like this. But still, every year, I keep telling myself I need to change it. I need to fix it. I need to do something. But of course, after all those lectures, I just forget about everything. So surgical abscesses intervention or phlegmons consist in revealing purulent hearts. Purulent sources, let's say like this. As I said you previously, there is a Latin proverb, ubi pus ibi inciso. It means where we have a pus, we have to do incision. Okay, so it's very obvious. We have to release that. For this purpose, the section span from chin department, lower jaw, to hyoid cyst, and something any cosmetics or regarding profitably conduct arched cut in the parallel chin parts, lower jaws, after dissection, skin and subcutaneous tissue, pulling the edges of the surgical wound to the sides can be bluntly or cutting deeper located tissue with a scalpel along the middle line body, blah blah blah. That's not interesting, absolutely not informatic. I really understand that, and I'm sorry about that, but we have to move forward. Sublingual plot with forms of soft tissues, not fabrics. Fabrics is a wrong word here. It's tissues. Limited from below maxillo-hyoid muscle. It calls diaphragm of the mouth. Not sure that you use that in anatomy, but still we use that notion here. Above it, it's a mucous membrane, the lining of the mouth, outside and inside, surface bodies, lower jaw, and from the inside, the chin lingual and chin hyoid muscle. It means the borders of that space, that area. Let's move on. Treatment. Trying to find something very necessary, because the treatment of all phlegmons and abscesses is very similar. You have to just do incision and release the pus, but still there is some kind of small peculiarities in different regions, but it's mostly the same. Yeah, this case is most of a complex problem of the floor of the mouth, because it's very hard to deal with that, but still, of course, we have to know that it exists. Not sure that I should read all that things. Submandibular close. Most of very often cases is submandibular, because the lower molars, the sixth, seventh, and eighth, provoke that submandibular problems, especially in children. Yeah, so first feature, it's the It's the different of treatment abscesses and phlegmons of short and hard palate. What is the difference? The difference is that as you remember, when we talk about periosteum of the palate, the acute purulent periosteum of palate, the incision that we made was triangle. Why triangle? Because if you do just incision like line incision, it's not it doesn't work on palate because it's very very fast healing, so there is no evacuation of problem. So that's why we need to do some very triangle incision. Here we have the same. So we need to do that incision here, triangle, to have that condition to evacuation of our pus on the palate. That's the first very. It's a huge explosions here. Sorry if you hear that. But still, I have to keep conduct our lecture. Quite often, when patients seek medical help late, it's a huge problem actually, because patients just do nothing. They just do nothing. They just keep waiting for something. They just thinking that, okay, it will move itself. Okay, I will put some onion or garlic or I don't know what, cabbage or what people do. You know that cases, right? So they put everything on their problem places and keep thinking that it will help, but it's not. So when they seek late for help, it means, and when medical professionals make diagnostic and tactical errors, that's what we talk about. The inflammatory process in the maxillary soft tissues progresses and gradually spreads to neighboring areas. And in this case, we call that secondary. You remember there was a deep, superficial, and secondary. So it means secondary when it spreads to neighboring areas. At the same time, purulent exudate moves along the intermuscular and interfacial spaces, along the perineutral and perivasal tissues. This can lead to secondary purulent inflammatory processes in the ciliary spaces of the neck. A very hard complication as a thrombophlebitis of the facial veins, sinus thrombosis, meningoencephalitis, or encephalitis, I suppose, modern diagnostics of which is the key to the correct choice of further medical, in particular surgical, tactics, which significantly reduces the likelihood of the patient's death from terrible complications. Those as mediastinitis, brain abscess, and sepsis, increasing the chances of recovery. And yes, our problem tooth with some odontogenic process and pus could lead into death. It's very seriously. Your wrong endodontic treatment could have very seriously complications. Your extra irrigation with hypochloritis could provoke necrosis of periapical tissues, Amal. I suppose you hear me. So that's a
Yes,
huge problem. If you work
yeah,
as an assistant, as I know, and your doctor use irrigation for root canals, and if
yes.
you put too much, not even
Hypocrite,
too much,
yeah,
just
accent.
yeah, over your apex.
Yes.
That is a huge
Yes.
problem.
Yes.
So irrigation of root canal should be very, very soft and responsible, because you have to understand that if you put that over, you have the no, wait.
Hypochlorite accidents.
Yeah, it calls like this, but I wanted to remember the name of the necrosis. Oh, coliquatic necrosis, I suppose in English, but not sure. So it's a huge problem. It's a really huge problem. So of course, your endodontic treatment could provoke periodontitis. Periodontitis could provoke periostitis. Periostitis, osteomyelitis, and then abscesses, and then phlegmon, and then meningoencephalitis, and then maybe, I don't know, thrombophlebitis, sepsis, brain abscess, and death. Very nice root canal treatment.
Yes.
Cool, right? So
Yeah.
I wanted that you understand, be careful. It's very, very responsible.
Yeah.
Whew. Move on. Pterygopollating fossa. Okay. You know where it is. That's not interesting. That's not interesting. Pterygomandibular space. Okay. Yeah. Still okay. Very, very understandable. Granting assistant patient with abscess and phlegmon, general and local. Oh yeah, let's talk about general assistance. That's what I wanted to stop here. So the main methods, it means to all problems, to all abscesses and phlegmons, of treatment, are holding surgical operation in the required volume. It means it includes dissection and drainage affected cellulose traces. I don't remember if we said that what is phlegmon. So phlegmon is inflammation of cellulose spaces with no borders. So it's diffuse inflammation. So no limited, no capsule. Like an abscess has some capsule. Phlegmon has not any borders, so it's very diffuse. Maybe that word exists, not sure. Okay, so medicamentous treatment is divided into general and local, means here. So in localis, in genesis, and includes antibacterial, of course, detoxification, of course, hypersensitizing, of course, in general, straightening therapy. Straightening, sorry. As I said, we have a background. So if we have a bad background as a lack of immunity, we have to deal with that to put it on the normal level. Local medicinal medical treatment comes, it should be medical, comes down to washing purulent wound with solutions. Washing, not sure, it's let's say irrigation, okay, with solutions, antiseptics, introduction of ointments into wound and cavities which contain antibiotics, overlay antiseptic bandages and compresses after liquidation shock. Inflammatory phenomena are being eliminated. Source infection, removal of the causal tooth. We call that causal tooth. That was the origin of infection. Or tonsillectomy if we had Tonsilogenic, if you remember, but that's not our deal. We move it to another doctors who deal with pharynx. In some cases of odontogenic processes and the absence of technical difficulties, reflexive inflammatory contracture removal of the causal tooth can, and it's better, be performed before surgery of the phlegmons or at the same time as phlegmon means. Okay, and the most interesting things here, it's very different phlegmon that calls Ludwig's angina or angina ludovici or angina Jean Ludwig, or it should be pronounced differently in each country. Okay, but the reason the meaning is the same. It's a rapidly spreading bilateral indurated cellulitis occurring in the floor of the mouth without abscess formation or lymphatic involvement. Very dangerous state, very extremely dangerous state. What is the difference? The difference is a microflora here. The purulent necrotic phlegmon of the floor of the mouth in development whose a significant role belongs to mixed and anaerobic microflora. Those guys, anaerobic microflora, provoke that extremely hard state. Developing repeatedly, in clinical, the picture signs intoxication. I mean, a strong intoxication prevail over a local manifestation disease that reflects pathological essence, disinfection process, dominance, alteration, or necrosis over exudation and proliferation. Patients, Jesus, patients, they adynamic, so they not moving a lot, okay? Adynamic, I suppose you know that word. Less often are in a state of euphoria and leather covering, pale with earthy shade. Tissue turgor is reduced. It is observed subcutaneous sclera, body temperature very high. It is noted difficult breathing and inability to talk. Patients accept forced position sitting. I recommend you to take a look on that disease because it is in a croc. There's a question about angina Jean-Sula-Ludwig or Jean-Ludwig or Jean-Ludovic or just Ludovici or Louis or anything. Not sure how you call that in your country. Let me know that if you know. In the submental and submandibular areas appears dense, painful infiltrate without clear boundaries. It means limit or limit. On palpation, they have some crepitation. Crepitation is an interesting thing. It's when you palpating the soft tissues, they make some noise like you stepping on the snow. If you know what is that, not sure
Yeah.
because
Yes, yes.
you know what is that. You have the snow in
Yeah.
Morocco.
Yes.
Oh, really? Okay. Okay, so
Yeah.
when you step in on the snow, there's a
Yes.
so that is a crepitation. So when you palpating the patient with angina Jean-Sula-Ludwig, you have the crepitation. The crepitation is some some I cannot explain it. Some they broke some gas, very smelly, not good smelly gas. So there is a small bubbles of gas in soft tissues. Okay, so when you palpating that, it is like this.
Okay.
Remember that, because that should be in a crock. The sublingual ridges have appearance duplicate tongue, mucous, the lining of the floor of the mouth is covered in fibrinous films. Hyperemic, okay, after autopsy, the large number of found necrotic masses in purulent center and purulent exudate dirty gray color with bubbles area. Here we go. Here there is a bubbles area and the sharp unpleasant smell. Yeah, mussels have appeared of cooked meat. Really, really. The same explanation in the crock. So remember that. If you see any of that signs, at least they have 2 or even 3 signs of angina Jean-Sous-la-Ludwig. So it's absolutely no problem to distinguish it from other phlegmons. Okay? Okay.
Okay.
Whew. Let's move on. It's a huge, huge explosion. What is going on? Okay, results. Significant immunosuppression as a background, we know that already, which manifests itself leukopenia, lymphopenia, decreased phagocytic activities, neutrophils, decreased humoral factors immunity, and non-specific factors protection. Prognosis of petrificative necrotic phlegmon of the floor of the mouth is very serious. In most cases, depends on timely start of therapy. Such sick need, it means patients need urgent surgical intervention against the background, general intensive therapy. Operative intervention necessary carry out under general anesthesia, of course, and it is expressed in wide open cellulose spaces, all affected and adjacent areas. Cut open is more relational in disclosure these one phlegmons in order to increase efficiency antibacterial postoperative therapy period spent regional infusion antibiotics. Prescribed metronidazole is administered hyperbaric oxygenation. If you remember, I showed you that capsule on the 5th lecture when we talk about specific inflammatory processes. Not sure if you remember that, but still, it helps. Why? Oxygen, hyperbaric oxygenation. Put more oxygen in your bloodstream, and oxygen is killing the anaerobic microflora. That is the main cause of angina Jean-Sous-la-Ludwig. Okay, it's very, very understandable. And local oxygen therapy of the wound, if available, sign gas, gangrene, enter antigangrenose polyvalent serum that contains antitoxins against 3 species pathogens, gas, gangrene. Very, very extremely hard condition. As I said, very hard to treat, very hard to deal with that, but still we have to do maximum that we can do. Most of cases, even most of cases, it could be problem with children, not with the adult people. So it's very necessary to start the treatment aussitôt. I don't know how to say it in English. When you see the first sign of that, as fast as you see the okay.
As fast as,
Yeah,
yes.
yeah, 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 yeah. Okay. Whew. Typical incisions in the surgical treatment of abscesses and phlegmons, you can see on that picture why it's so necessary. You cannot do any incision amount as you want. like Picasso, la, 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 la. Yeah, no, it's not possible. You have to deal with some nerves and vessels and muscles and features of skin of the face and neck. So that is the places when you can do safe incisions. Okay, remember about facial nerve, about arteria facialis, and all that things. And second one reason that we have some aesthetic parts of that. Okay, so when you do the incision like this, you minimize the scarification of patient. Okay, and of course it's very necessary for women, for example, to not make all those aesthetic problems, okay, to minimize them. I think that you agree with me. You would
Of
not,
course.
yeah, you would not want to some lot of scars on your face. Not good
Of course.
for women. But for men, it's okay because girls like some dangerous guys, right?
Yeah.
Okay, so we have the second part of our lecture. As you remember, the maxillary antrum is remembered from the first course, first year of anatomy, right? Um, it's the largest of paranasal sinuses. Its volume is on average 10 or 12 centimeter cubic, varying from 3 to 30. Proximity varies between individuals, but tends to increase with age as the antrum enlarges. Depending on the degree of pneumatization, pneumatic and sclerotic types of the maxillary sinus are distinguished. And that's very important for us if we talk about implantology and if we talk of augmentation of the maxillary bone for implantation. And of course, it's necessary for us to understand when we do an extractions of teeth of upper jaw, because the root can be involved into the maxillary antrum, right? Right. The sinus is divided into upper, inner, interolateral, posterolateral, and lower walls. Everything that you already know. The upper wall is the thinnest, especially in the posterior part. And often in the lower wall of the intraorbital canal, there are areas devoid of bone tissue 2 to 4 millimeters long. Okay, localization of those sinuses. We have four, sorry, types. We have frontal, it's green one, the cells of the ethmoid labyrinth, yep, the purple ones, the sphenoid sinus, and that we interested in is maxillary sinuses, is the blue one. The features of the location of the tips of the root of the teeth, too much off here, but still, of the upper jaw in relation to the maxillary sinus. Very, very necessary to understand that when you extract the tooth. The roots of the upper premolars and molars and the floor of the maxillary antrum are closely related and share a common innervation. As a result, dental symptoms and oroantral symptoms can mimic each other. Dental procedures may be complicated by problems involving the antrum, including creation of the oroantral communication, displacement of the foreign body into the antrum, and the fracture of the maxillary tuberculosity. Antral pathology may be incidentally demonstrated on the dental radiograph, but still be careful with the X-rays and radiographs, because if you use two-dimensional radiographs, as you remember, the orthopantomography is two-dimension picture of three-dimension space, as I told you before, when we talk about tooth extraction, and I showed you this guy, you know him, right? Things are not always what they seem. The first appearance divides many, the intelligence of few perceives what has been carefully hidden, said Thaddeus. But still remember that nothing that you see is the pure truth. Okay? Okay. I suppose, is that clear? Is that clear? Okay, anatomy of the paranasal sinuses. We have osteomythal complex, the main anatomical and functional unit of the nasal cavity. It's more in connected with the with not with dentistry, but still ONT therapy, right? The structures of the sinus. A very interesting thing here is the type of cells here. So the mucous membrane of the maxillary sinuses covers the bone walls and consists of three layers. The inner epithelial layer, represented mainly by ciliated, cylindrical, and occasionally mucous goblet cells. The middle layer, which includes acinar mucous glands located in the stroma, and the outer layer, which is dense connective tissue adjacent to the bone. Schematic representation of the maxillary sinus. Here we see the normal sinus on the left picture and inflamed sinus. Maxillary sinus means on the right picture you can see the edema of the mucous membrane. You can see the secretion or secret or just liquid, a mucous liquid, right, on the bottom of the sinus. That is a problem. And the hiatus, or the way connection between the sinus and nasal cavity, it's the medium natus. It closed. It closed because of inflamed tissues. They get bigger, so they just strict that hiatus. So the evacuation of all that problem cannot be possible. That's how all problems starts, and all that liquid, it's getting more and more infected, and then we have some purulent process, and then we have huge nasal manifestation. Acute sinusitis, if we talk about clinical manifestation, affect any of the paranasal sinuses, but are usually confined at any one time to a single sinus. It is a bacterial infection and typically occurs after a viral upper respiratory tract infection. It could be Haemophilus, Pneumococcus, Streptococcus, Staphylococcus species, and anaerobes are commonly found. Very typical, guys, right? Right. Maxillary sinusitis is usually related to impaired antral drainage, which may be caused by mechanical obstruction of the ostium resulting from inflammatory edema of the nasal mucosa due to a common cold, ethmoid polyps, or deviated nasal septum. And second cause is impaired mucus clearance resulting from maxillary action, for example, related to the mucosal damage caused by chronic infection or surgical stripping, or the viral damage caused by a common cold, or occasionally due to the rare conditions such as a primary ciliary dyskinesia. And we have abdominally thick or sticky mucus as found in cystic fibrosis. Accumulated secretions become infected. Secretions means bad liquid, okay? Become infected, allowing a collection of pus to develop in an antrum, as I said previously. Okay. Symptoms of acute sinusitis usually appear in a few days after the acute cold symptoms have resolved. Pain, headache, nasal obstruction, apparent nasal secretion, and post-nasal drip, discharge of mucus into the pharynx are commonly found, and there may also be fever and malaise. The pain is dull, heavy, throbbing, and located over the cheek and the upper teeth. It may resemble toothache, but is not related to hard, cold, or sweet stimuli, although it may be increased by biting. Typically, all of the posterior teeth on the affected side are painful and tender to prescription. Oh, sorry, precaution. Although often no obvious dental cause can be found, a clinical sign of sinusitis, we have sign of a recent upper respiratory tract infection, for example, rhinorrhea, nasal redness, dryness, or crusting, tenderness of the cheek, especially in the anteroorbital region and canine fossa, tenderness of teeth in orbital segment 2, percussional pressure, tenderness over the anterior antral wall intraorally, and swelling and inflammation of the cheek, rare in sinusitis. What is most needful for you, okay? It is the oroantral communication. Very bad complication after tooth extraction. Very hard complication. So we have the following complication that occur during the extraction of posterior maxillary teeth because of the close proximity to the maxillary antrum, creation of oroantral communication, displacement of a tooth or a root into the antrum, and fracture of the maxillary tuberosity. Maxillary premolars and permanent molars are most frequently implicated, although permanent canines may occasionally be close to the antrum. Complications may also occur during the surgical removal of impacted, partially erupted, or unerupted teeth, for example, canine premolars and third molars. The extraction of deciduous teeth does not present a risk due to the relatively small size of the antrum in the children and the presence of the developing permanent teeth. Oroantral communication and fistula. An oroantral communication is an abnormal connection between the oral and antral cavities. An oroantral fistula is an epithelialized oroantral communication, although the term first and second one are often used interchangeably. The creation of oroantral communication most commonly follows the extraction of the maxillary tooth close related to the antral floor, typically the first molar, which lies close to the lowest point of the oral floor, although any premolar or molar may be affected. An oroantral communication may also form as a result of an alveolar fracture running through the antral floor or wall, or be due to direct trauma from the burr or chisel. Left untreated, an oroantral communication may heal spontaneously or persist as an oroantral fistula. Treatment of oroantral communication. The immediate treatment of new oral communication is aimed at preventing the development of a persistent oroantral fistula and chronic sinusitis. Larger communications require surgical closure, although small defect up to 5 millimeter wide may heal spontaneously. It is likely that many close without being detected. However, early surgical closure is recommended whenever possible, as it is difficult to predict when spontaneous healing will occur. I could say that it depends. It depends on your patient. It depends on his age. It depends on how much hard tissues, the bone of maxilla left, or how many soft tissues you have. So it depends. It depends. It depends. And yeah, if you have something less than 5 millimeters, you can keep like this. So organism should deal with that. If not, it should be better to put some sutures for that, okay? And I recommend you to suture that, and even if that less than 5 millimeters. We have few techniques. That's not so big deal. You can do that in your dental office. It's absolutely not high-tech maxillo-facial surgery. You can do that without any problems. At least you have some skills for that, okay? But still, it's possible. Pharmacological treatment of oral disease, antibiotics, of course, it's obvious. Decongestant nasal drops and steam inhalations are prescribed for the prevention of sinus infection following the creation of oral communication. Broad-spectrum antibiotics are useful in the treatment of acute sinusitis, although they are not a substitute, for the drainage of pores. And decongestant nasal drops and steam inhalations can be used to encourage drainage, and the analgesics such as a paracetamol or ibuprofen may be recommended for relief of pain and acute sinusitis. About antibiotics, a suitable choice is amoxicillin or erythromycin. Why we have to put the decongestant nasal drops? It is necessary to do the vasoconstrictions. So they provoke vasoconstriction. Vasoconstriction reduce the edema of the mucus here, and that hiatus that connect your sinus and nasal cavity. It's open, so it create the conditions when the cells, those cells that we have in the antrum, maxillary and antrum, they evacuate all that mucous liquid, infected liquid. So that's why we have to prescribe the nasal drops